by Elliot Jocelyn. So as the disease happens to be a silent killer disease, probably we need to be more careful in the patient education, and Dr. Selvapandiyan is going to highlight about the practical tips on diabetic patient education. I hand over the mic to Dr. Selvapandiyan. Thank you.
Good morning, doctors. At the outset, I would like to thank Dr. Ravinath for his kind words. And really, today my task is to talk on practical tips. Normally, about diabetic education, everybody we talk about diabetes, what is epidemiology, and how it comes, and what are the treatment methods, and everything we talk. But when it comes to the doctor and patient over the table, because we can't be talking the total diabetic education and other things over the table, because it will take a long time, and by itself it's a separate subject. So we have to understand the patient and what is his problem. Then according to that, if you are going to give a specific education or something, then it will be a kind of motivation where the patient fault has been understood by the doctor, and then we can specifically address this fault, and we can give him an education or a motivation where he will adhere to the treatment. Because many a times what happens, the patient follows the same medication, same prescription. If you are going in a bus, the same route the bus will be going, the driver, everybody is the same. But with the same ticket, you can't travel the next day, unless you should have a pass. So like that, the patient will be following the same prescription, or he'll be coming after 3 years to you and he'll be telling, doctor, I'm following the same medication, I have not seen any other doctor, only your prescription I'm doing. Like this, these kind of problems will be coming, and how to tackle at those times, and how to motivate. So these are things we are going to see. So this is a health tips to start with humor. If you can't afford a doctor, go to an airport, you'll get a free X-ray and a breast exam, and if you mention Al-Qaeda, you'll get a free endoscopy, colonoscopy also. So as Dr. Ravinath was telling, patient education is the main milestone of the diabetic management. Without the patient understanding the disease, a doctor can't manage the patient, or the patient can't adhere to the treatment. So it is very important, a diabetic patient in the first visit itself should understand about the disease and what is the progression of the disease and what will be the management in the future and in the present. This has to be first discussed with the patient, and then only you can follow up the patient very well. Because mostly diabetes, as we all know, it's a silent killer, and it is asymptomatic by accidental diagnosis only. Many a times diabetes is diagnosed only by accident or due to some other causes, and it needs frequent monitoring. That is one aspect. Patient, because of the asymptomatic nature, patient never complains of anything. He'll say, I'm fine, sir, that's what I never came to you or something. So it has to be monitored frequently, and that micro and macrovascular complications, according to the time we have to evaluate and at least prevent or delay these complications. So the father of diabetology I used to call Prof Sam GP Moses. He has taught a lot of, because his idioms, a lot of idioms he used to tell, that will be a motivating factor. In diabetes he used to tell, more urine, more money, and no urine, no money. Because as the disease starts, the patient will be having symptomatically, he'll be having polyuria, more of urine, and he'll be having a lot of money also. But at the end, because of not adhering to the proper management, lastly the patient will be having no urine, kidney failure, and all the money has to be, all the savings, everything goes into the management, and the family is at problem. So this is how the diabetes goes. So if you are going to pass this message to the patient understands the disease, and he'll be adhering to the treatment, and he'll follow the regimen. So like that, these kind of idioms might be very useful. And he used to tell the doctors also about prazosin and alpha blocker. He used to tell it's a joker card. You can use it with all the antihypertensives. You can use this alpha blocker. It will have a very good stabilization of BP or something like that. And for neurogenic blood, like that, you'll be having a lot of idioms. These kind of things, when we talk in the easy language of the patient understands the disease, and he also tries to adhere to your treatment plan. So when you are treating diabetes, I think mostly it is like treating as school children. The boy might be a very good boy. He will go timely to the school. He will listen to the class. He will be a very non-problematic child in the school. He will come back exactly from the school after the school closes, come home, and at the time he will open the book and he will be sitting there reading or something like that. But when you are going to understand about this student, whether he is a good student or he has followed his lecture classes, or he is going to shine only during the exam, during a cycle test or something like that only. A diabetic, he never has any symptoms, he moves quietly, he does all his work, but when he is not going to monitor his diabetes periodically, you can't say that diabetes is under control. So like a school student only, we have to monitor the diabetic patient, like weekly test, monthly test, cyclic test, like annual test and all. In diabetes also we have monthly what test, weekly what test, according to the patient profile, according to the patient diabetic duration. The test also varies, the frequency varies. So this has to be explained to the patient. And according to that test results, the action is going to be taken. That we all know. And one thing is, in the school, a better performance in the primary education with the student results in better results in later years of education or career. This can happen or cannot happen in a student life. But in diabetes, this can happen. How? That is the metabolic memory. This has to be passed to the patient. He has to understand what is that legacy effect, because it has been proved. This metabolic memory is nothing but the legacy effect. Initial 5 to 7 years of good metabolic control reduces or prevents the complications of diabetes, even in the patients is not intensely treated in the later years. This is a very important information. So in the initial period of diagnosis, when managing a patient very well, intensively cared, in the later years it has been found they are not having any cardiac events, other things have been reduced. So that has been well proved with this UKPDs and DCCT. So that's what a student in the primary school he might not shine well, but he might shine well in the higher education. But in diabetes, this is a legacy effect. So, and thus the first visit becomes the golden hour in a diabetic management. So these kind of messages has to be passed to the patient. They have to be made understand, because initially when the patient comes to you, you clear the glucotoxicity. His symptoms, everything goes up. Then after some months, what happens? He starts taking sweets and other things, and he comes to you with the test result, and he'll be telling, see doctor, today my postprandial is only 140. You know what I did? I never took the tablet. I took a small sweet also, but my sugar is under control. How is that I had diabetes? You diagnosed 300 or something like that in the beginning. So to accept that he is a diabetic, it takes at least minimum 2 years for a patient. That is the thing. In this scenario, the patient might wonder, what the doctor told, I am a diabetic some 3 months, and now I am eating sweet also, but my sugar is under control. So like these kind of doubts will be often pestering in the minds of the patient. So they have to be slowly motivated and educated. And what happens? Many a times you can see, the patient will be either literate patient or a illiterate patient. They'll stop the treatment. They'll be, no sir, I wanted to see you and then start the treatment, because I never had any complaints. I'm very comfortable. So I thought I'll meet you. To meet you, it got delayed 3 weeks, 4 weeks, or even 3 months. So I wanted to see you, sir, because you might change the time. They'll be keeping some other reasons for that, for the delay or stopping the treatment. But they should understand, stopping the treatment is getting down a running bus. So the doctor becomes a driver. Without informing the driver, if you are going to get down from the bus, you are going to face disastrous consequences. So these kind of examples over the table. If the patient is not coming properly, stopping the treatment. So these kind of educations are very important and imperative in a diabetic clinic, where a doctor and patient are over the table. So these kind of things. You can also form some innovative ideas to motivate the patients. These are all motivating, because we can't be talking about the total diabetic education to the patient every time. So find out where is the fault, whether the patient is stopping the treatment or not adhering to the treatment. Like that we have to identify, and then accordingly we have to react. Then many times you can see the patient will be, you have 10 antihypertensive tablets, lipid tablets, everything, but the patient will be taking only diabetic tablet. He'll be telling, no sir, I stopped all other things. Why? So we should make them understand, will you eat only white rice without sambar, kuttu, poriyal and other things? Like that, it is like taking only white rice, leaving the sambar, rasam, kuttu, poriyal, everything, and that is how the patient is taking only anti-diabetic medication. So the patient, even the literate patients, they think that diabetes means only controlling the sugar. They should understand it is not only the sugar control, it is the diet control, exercise, BP medication, lipid medication, everything has to be put together, and then only everything has to be controlled, then only this diabetes is controlled. They will be simply talking to you only about the sugar. Sir, I saw 2 days back, my sugar was 180 postprandial. I saw some 1 week back, my fasting was 110. Like that they will be telling, but they will be never bother about the HbA1c or the BP or the weight or the food. They will never bother. So it is like taking only white rice without any sambar, rasam or puril. So this has to be tackled in this manner, because diabetes is a multifactorial risk factor which has to be managed with all the armamentariums. And many a time this you can see, they will come to in front of you and sit, then they will be telling, doctor, After 3 years, they'll be coming. And they'll be telling you, sir, I'm following only your prescription, sir. I'm very fine. I don't have any problem. I'm doing my work. I'm very fine. So how is it possible? Without doing any test or any relevant information, how we can tell by seeing the patient or without anything, how to say a patient that is under full control? So this happens many a times. So that's what I told. The same bus route only, the same destination only, and you are traveling daily on the same thing, but you can't travel with the same ticket. You should take a new prescription. You can't follow the same prescription for years together. The prescription might change because diabetes is a progressive disease. This the patient has to understand. First, the tablet would have been, the patient would have been managed only with diet and exercise. Then you might require some tablets. Then after some years, you might require insulin also. So this thing, the patient has to understand that he should not take the same medications for years together or something without the doctor's new prescription. And that has to be emphasized. And HbA1c, this many a times because of economic reasons, we doctors, we healthcare providers itself have some kind of discrepancy, but the HbA1c is mere waste because it is not been standardized, and why to follow that, and these kind of things are there. Let it be a standardized one, and HbA1c is very important. The patients should understand that it is like a it shows the glucose load of the patient, because no other prognostic tool is there, because unless and otherwise if the patient is doing a regular SMBG, self-monitoring of blood glucose every week, that is once in the 1 week in the before breakfast and after breakfast, then the next week if he is going to do for the lunch, and the next week like that if he is going to monitor, we can't tell that patient is having a good control. So now the only prognostic tool what we have is this thing HbA1c, and recently Dr. Ramchandran 2 days back also he revealed some study in Chennai that HbA1c, with HbA1c itself 55% of the patients are found to be diabetic in the Indian scenario. So this is all a welcoming change, and this has to be emphasized to the patient, and the patient should understand about this test, because a patient who is coming after some 3-4 months or something without any test, this HbA1c is going to help you. See to that it is done in a very standardized lab and in a standardized method. And this has to be told that it's like a gulab jamun. The jeera, if the more the sugar thing thicker and sugar in the jeera will be reflected in the gulab jamun, and like that only the glucose load, the prolonged glucose load is going to be reflected by HbA1c. And we used to say that one test is equal to really for the past time, because many a times patients come with only one reading after 3 months. How is that? Daily sugar rises at least for the breakfast, lunch and dinner 3 times, monthly 90 times. So 3 months if we take 270 times. For this 270 times, 1 pot of rice can be told with only one rice, that whether it is boiled or not. But not the same thing with sugar. With one sugar reading, you can't tell that the patient is under control or not. So we need some kind of other investigation, and this investigation is going to be the best, and this has to be told to the patient like this and made him understand. And again, electricity also can't be stored for a longer time. It is only temporarily, like battery life or something. Even your glucose gets stored as glycogen in the muscles and other tissues, and that is also only for 24 hours or something, and then it gets it's like only for a temporary period, and then this glycogen gets transformed into saturated fat, and this fat has been in the liver, it has been regulated by insulin. This has to be somewhat educated or told to the patient and made him understand about the how he gets, because they will be thinking mostly fat is only with the oil or non-vegetarian foods and not with the other thing. Even your normal carbohydrate like idli, rice and other things how it gets converted into fat, that has to be told to the patient and educated. And the fate of fat, excess fat is like ectopic fat, it gets deposited in the blood vessels and causes MI and other things. This has to be with some picture things, you have to show the patient about the normal blood vessel and how the blood cholesterol get deposited in the blood vessels and how the blood vessels get narrowed, but still your ECG can be normal, your angiogram can be normal, but how the blood vessels get deposited with the fat and how the blood vessels get narrowed. This has to be somewhat explained to the patient. And about the visceral fat, that is the central adiposity, which is the active fat, and how this fat is like black money, and how this affects the macrovascular complication, how it causes. Everything has to be told in an easy language so that the patient can understand. You can form your own kind of idioms and tell the patient according to your patient in his easy language. And microvascular complications, it is because of how these complications occurs. persistent high sugar, uncontrolled sugars, how it affects the endothelium and how it brings out the complication. This has also been told because we have vessels ranging from micro vessels to nearly big aortas. So these kind of blood vessels are different blood vessels are there, and how these blood vessels in the thing when the cholesterol is going to get deposited, all these blood vessels are going to affect it. So the micro vessels are going to get affected in the early stages. And later what happens, it's going to be the bigger vessels. So this has to be told to the patient because of the high blood sugars, how these high blood sugars causes high cholesterol and complications because of advanced glycogen products. And first, we have a separate food workshop. You'll be having a lot of information in that, so I'm not going to talk much about that. But still, many a times our patients will be coming and telling, sir, what for you are living? I'm now earning very well and other things, but I can't eat the food which I like. This is the main thing. When I had no money, when I wanted to have some food, at that time I had no money. But now I have a lot of money, but I couldn't have anything. So what is the use? So first the patient has to understand whether he is eating to live or living to eat. This has to be answered by the question, because in the same world, the other part of the world, there are people who can't afford even for one meal. That has to be told to the patient and educate them. It is not that they are living only to eat, So this has to be made clear to the patient, and overeating is again wrong. How to space the feeds, this has to be explained. And the finger eating, when you are taking with the hands, you are going to tend to take more of amount of food or something. So ask the patient to go with spoon or fork or other things that will reduce this hunger pangs, and he can reduce the food quantity. So like that, some kind of education has to be imparted. And insulin, many a time still this insulin is a myth is there with all the patients, whether even our same colleagues, when they have some opportunity to go for insulin, again they also don't accept. They say, sir, why insulin, sir, we'll go for. So they should understand the importance of insulin. See, you take any other endocrine problem, we have some kind of oral medications, and it has been managed. But in diabetes, what happens? Insulin is available only as injection form, but tablet forms are going to come. We have to wait for that. But still, there are a lot of myths with the people that has to be cleared. And because how we are going to clear, we have to tell about the progression of the disease. What is the progression? What we are doing, and we are not curing the diabetes. And now the progression reduces the beta cell exhaustion. At the time, what happens to the beta cells, and after that, what happens to the beta cells, everything has to be told to the patient in the initial visit itself. Then only the patient can understand about the progression of the disease, and he might accept for an insulin. Food care again, many a times, because in our culture, we never we neglect the food like anything. We never take any special kind of precautions or preventions for food, because barefoot walking is still a common phenomenon in our country, and that has to be emphasized to the patient, and he has to be taught, and high-risk patients should be told how to prevent the food complications and how to take care of the foods. And in every visit, we should examine the food. By that itself, we can reduce the food complications. And if it is a high-risk food, you have to identify the high-risk foods, and accordingly, we have to give the preventions and safeguard those patients and prevent the complications. Eye care again, in type 1 diabetes, we can see that because they say in diabetes is the main cause for blindness, but we don't see that much of thing because our patients never reach that stage, I think so. That's why we are not seeing. Only in type 1 diabetes we are seeing that kind of blindness. And even in type 1 diabetes, in our patient scenario, we don't see that patient live so longer to have these complications and live. And in type 2 diabetes again, even though the endogenous insulin has some C-peptide, and that causes some prevention of microvascular complication, but still we tend to have this thing because of uncontrolled sugars. And many patients because now the retinopathy has become the incidence is more, and the laser treatments are very common. Because of this, we are seeing, because whenever the patient is being advised for laser, I think it's better to take a second opinion. Otherwise, what happens? Taking the laser treatment, you can see the patient, he'll be having a tubular or central vision, that side view will be lost, and when he's walking in the road or something, he might have to meet some accident or something, which is a common thing. So, whenever you are going to do a laser therapy or something, make sure that the patient needs absolutely the laser therapy, and then it will be better, I think so. Again, ESRD, I think we don't see patients live so long, and this is also the patients die before that. That's what the ESRD patients, we don't see that much, they live till the end stage. But peripheral neuropathy is a very common phenomenon in our region, and the symptoms vary. We say that neuropathy mostly asymptomatic, but still they have some kind of very vague symptom which has to be elicited early, and we should not neglect any patient's symptoms of saying that I am having a pain or some kind of vague presentation should not be neglected. That's what I mean. So try to find out and treat early so that you can prevent the progression or delay the progressions. Again, the diabetic or the vascular age is totally different from the chronological age, because diabetes is a vascular disease. The vascular aging is a very important thing. Many studies have proven that in men it is nearly a diabetic. Lifetime is reduced nearly 1 decade in men, and I think 8 years in men and 10 years in female. We are having a lot of studies. So vascular age has to be told to the patient so that they can lead a normal life with good diabetic control. So to conclude, we all know that diabetic education is a very important thing, and it should be told in the first visit itself what is the disease progression in that patient, and how it is going to be managed now and in the future also. That this has to be discussed with the patient and convince him. That is a very important thing, because if you are going to miss the first visit counseling or the diabetic education, the patient is never going to listen. After going in for some complication, then only he may trailers. So please, in the first hour, that's what I told, in the first visit is a golden hour. Don't miss that opportunity. Try to discuss with the patient about the disease of his nature and the other things, how to manage. And motivate by explaining in easy language. As I told you, there are so many idioms which you can use and by which you can educate the patient. And frequent monitoring. What is the importance of frequent monitoring and regular investigations? Because patients believe only sugar test is enough. They measure only the sugar and not the other things. So you have to emphasize about the multifactorial management of diabetes. And early detection, this is a very important thing, and to prevent or delay the complication and to lead a normal life, we should detect everything earlier, and by this we can have a very cost-effective management. And that is also very important region, because diabetes management day by day it is going very, cost is going up, so that has to be taken care. And to prevent, by this we can prevent the loss of economy and manpower in our country, and will have a productive and developed India. So prevent the epidemic by teaching the lifestyle modification angle, because like our President, ex-President Dr. Abdul Kalam has told, if you want to prevent diabetes, catch hold of the young girls, teach them about the lifestyle modification, because she is going to be the take care of the home, the husband, the children, the mother, father, mother, everything. So if you catch